Welcome everybody. This is a family medicine and School of Population and Global Health jointly run webinar series on global health. Today's session is about the 5th in the series. We started the series back in January and have had monthly webinars on topics of interest to global health, nationally, internationally, locally, and so on. Today's webinar is something that is particularly dear to my heart because one of my colleagues is going to be speaking, and I will turn the floor over shortly to Tim Evans of the School of Population and Global Health to introduce the two speakers. But I just wanted to say, Dr. Jimenez will be speaking about La Maison Bleue, where I also worked for many years back in the beginning. And Dr. Jimenez and I have a very close personal relationship, which is now 24 years ago. So I remember poor Dr. Jimenez coming to the hospital for me at 4 in the morning because my son was born at 4:03, and then having some big meeting the next day with some ministre de la Santé or something and falling asleep in front of him. I don't know if you remember that, Vanya, but you told me about that at the time. So just to say, we are making connections between people in the department that we all know well. And I'm also delighted to have Kate Mulligan here. And with that, I'm going to turn the floor over to Tim Evans for the introduction of our speakers.
Thanks very much, Marion. And I have the privilege of introducing our speakers today. We have two speakers. The first, as Marion says, a colleague of hers, Dr. Vanya Jimenez, who's a researcher, clinician, obstetrician, psychotherapist, and family physician practicing in Montreal. In 1999, she was named the Canadian Family Physician of the Year by the College of Family Physicians of Canada. And she's currently head of the Family Medicine Unit and of Medical Services at the CSSS Côte des Neiges in Montreal. Since 2006, she has served as president of La Maison Bleue. She'll be followed by Dr. Kate Mulligan, who's an assistant professor of social and behavioral sciences at the University of Toronto's Dalla Lana School of Public Health. And she's currently leading a commission report on the future of community resilience in public health for the Office of the Chief Public Health Officer of Canada. She previously served as Director of Policy and Communication at the Alliance for Healthier Communities, a network of community-governed primary healthcare organizations. So welcome to our two guests, and I believe our first speaker is Dr. Vanya Jimenez. Welcome, Vanya.
Thank you. So I'm going to share my screen. There are little corrections. I'm no more the unit director at CLSC Côte des Neiges. And yes, I've been here for a very long time. And your story is true, Marion. So I hope, and you're going to see one of my big fragilities, which is with internet and all the new stuff. So I have to do share. Okay, is this working? But I have to do something else, I guess, to...
Vanya, you have to go to the bottom and click on that thing that you clicked on the last time. A little bit more left, a little bit more left. Go up a bit. No, up.
Up.
Go up, up, there. Nope,
there.
Nope, nope, to the right. That one.
That
click
one.
On that one, yeah.
Diaporama. Okay.
Voila.
Okay, and then every time I click, it's going to move?
Yes, you have to do a down arrow or something to move it.
I don't see, but okay.
On your keyboard.
On the computer. Okay. Okay. So Maison Bleue, I'm going to be presenting this sort of formally with a bunch of slides, but then I will talk more myself. I like telling stories. So I named this From Knowledge to Action just to tell you the story of La Maison Bleue. How did research lead to La Maison Bleue? So it goes back to 1998, right? When there were the Le Grand Verglas, the storm, the ice storm in Montreal. And there were some studies that came out and looked at the effect of that stress on the mothers who were pregnant at the time. And there were significant effects on the development of the babies. Just to say that the environment has something to do with what happens to the baby. Enfant de la catastrophe. So we know, so imagine for people who go through much worse situations than the ice storm, and they're pregnant. So just imagine what it can do now that we know that the environment has an effect on the biology. Okay, so Dr. Evans was saying that I was a researcher. Yes, I did do two studies that I would say were the foundations for what made me want to start Maison Bleue. Then I'll tell you another reason why I thought Maison Bleue was an essential service. Funded by SSHRC, I explored the perception of taking into account the cultural differences in the system. So we looked at caregivers, and we looked at women who were pregnant and had given birth. And we had an interesting disconnect. 80% of the caregivers said, yes, we take into account the culture. And interestingly, 80 or 81% of the women said no. No one was lying, but there was a clear disconnect between the two. So that was one research. The other one, there was a culture of fear around birth, no matter who the chosen care provider was. We looked at family physicians, obstetricians, and midwives. So this is what prompted me. So this I just told you about there. Okay, so by then, as I say here, the Maison Bleue was looming in the horizon. Something had to be done. And then there was, that's the third reason, I work in a CLSC. CLSC is supposed to be interdisciplinary connectedness between all the professions. I did many deliveries. One, a founding delivery for me was a mother of 6. I attended all 6 births who were from 6 different fathers. A quite vulnerable woman. 2 children were either autistic or DYP was involved. And it happened at some point that I heard that there was a meeting called to discuss one of the cases. And I had no idea that that meeting was taking place. I asked, oh, I should have been there. I know this family. And I was told that they just forgot to invite me. So at this point, I thought, it's not going to work. I need to do something else. Within the system, it's too big. People are in good faith, but it's not working. We have to do something smaller and sort of outside of the system, but still closely connected to the system. More justification was needed, and Michael Meany, who I'm sure some of you know, who did this founding work on the impact on the DNA, in fact, was involved with us early on with the MAVAN study, and which is maternal adversity, vulnerability, neurodevelopment, and this was funded. It goes back to 2003. And he brilliantly illustrated the fact that in fact the chemistry of the DNA is affected by the environment. So this is how we started La Maison Bleue. Out of it, I would say, and Marianne was very much a part of, I would say, a sense of frustration from the group of family medicine accoucheurs that we were. We had the feeling that we were doing like decent deliveries, but then we lost track of the families after they left the hospital, the vulnerable families. I will talk more about that as well. So this is one of our little boys there. And I will go back to the stories of La Maison Bleue, just to say that it's a natural outcome of a reflexive practice of a group of family physician accoucheurs, and it led to research. And I will show you what we did. We evaluated it, and we are in fact at the brink of doing more evaluation, and we'll talk about that in a minute as well. Okay, so evaluative study showed that whatever we're doing has some effect. It's affecting the late prematurity. Comparing with in French, l'indice Pompalon, which has to do with social vulnerability. We have an effect on that, and mostly the small for gestational babies were nearly comparing for what you expect in such in a similar population. We are having a good effect as well. Clearly, the numbers weren't huge. We were like in practice for, this is done over 3 years, so maybe the numbers were about 300 or 400 women, so the N was not very, very big. We need to redo the studies, and in fact, I know that Juan Pimentel is watching as well. We are looking at putting together a research team, if possible, to pursue this evaluation at this point. So yeah, this is what, so clearly the thing that we were most happy about was the breastfeeding, which was quite a success. So the care model is an interdisciplinary management of vulnerable families, which I will precise in a minute what we mean by vulnerable. It's an independent non-for-profit organization with a specific contract for public services. So it's very important to understand that it's hybrid. So the shell is private not-for-profit. So we have fundraising that we do, but the core business, the professionals, the social worker, the nurse, the educators are all employees of the system. And to me, who's a fierce defender of the public system, it's very important that it remains like that, that it doesn't go into a non-for-profit, totally independent model. So in fact, what we propose is that by optimizing the development of protection factors like personal competence as efficient utilization of resources, this is what is working. We're making a village, a nest. In fact, essentially what we're doing is that we're countering the fragmentation of services which vulnerable families, it's the worst thing that could happen to a family that's fragmented already, to be confronted with yet the fragmentation of the system, going from a physician to a social worker and so on and so forth. Okay, so now what do? I stop share, right? Okay. So essentially, La Maison Bleue is this project that now has 4 sites, one in Côte-des-Neiges, that was the initial Maison Bleue, one in Park Extension within the same CUs. Then there's been such request and such demand to open others that there is a 3rd Maison Bleue that opened in Saint-Michel, associated with University of Montreal and Maisonneuve-Rosemont. And now a 4th one, which just opened because of the pandemic. There was a delay in the opening in Verdun, and it's associated with the CHUM for at the moment, and planning to move into Notre Dame when Notre Dame becomes a community hospital where deliveries will happen. So the idea is to have the women followed at Maison Bleue, vulnerable women. I will tell you what kind of vulnerability we look at, by family physicians and midwives hand in hand, because Maison Bleue seems to be, for a time being, the only place in Canada, I think in Vancouver there is such a place as well, the South Community Clinic, where midwives and physicians work really hand in hand. They're like, until there's a problem, which is then referred to the physician. And then there is the nurse, the nursing help, the nurse which does all the vaccinations that are done. And it's a one-stop shopping. It's a small place. The social worker and educators and psychoeducators as well. And we follow the proposal of Maison Bleue is -9 months plus 5 years till the last child is 5 years old. The population we serve are what we call, I don't like very much the vulnerable. It's at risk of becoming, because women are very strong. The families that come to us are remarkable in resilience, but they have risk factors. Okay, so what we see in Côte des Neiges and Park Extension, because of the location, very much new immigrants, children, babies that are the result of rape in the country of origin, drug use, single parents, conjugal violence, a lot, extreme poverty. So that's the vulnerability, and there is the intake. The referral is done mostly by word of mouth now, and referral. Many Maison Bleue is known. So when, for instance, in the clinic, we see, I was supervising yesterday, and one of the residents presented a case, and I said, this is a Maison Bleue case, should have been, in fact, directed towards Maison Bleue. It would be the best remedy for this family. So that, and there is we take it on. There is a limit, because there is an agreement with the health system, which is to do 90 to 100 new pregnancies per year. So we have now served over 4,000 in the 4 places, about 4,000 people, because the pregnancies, the families, and because it's associated with the GMF, Groupe de Médecine de Famille, they are, when they sort of graduate, and Marion knows that very well, when they graduate from Maison Bleue, the proposal of the family physicians is to continue to remain their family doctor, but they have to leave Maison Bleue to leave the space for other people. The most important thing that happens at Maison Bleue, and it's unfortunately the thing that has stopped during the pandemic, are the groups. There is group prenatal care. That's I would say the most powerful thing that happens in the Maison Bleues, in terms of giving the what we call the portage, the cultural portage, and the empowerment of the women, and the creation of network, and breaking of the isolation. So I come to my discussion yesterday with Juan Pimentel, which we're doing this amazing, I think, proposal, which is looking at what he called the most significant change. We're going to be exploring it in a qualitative way, sorry, to find out what how the impact is happening. Parallel to that, we do need to do evaluation of the development of children, continue what we've done, the prematurity, the small for gestation age study that ended about 5 years ago. We need to rekindle that. And I'm going to be hopefully approaching the department to set up maybe a study team to look at that. So 2 parallel streams for research, what we're building with Juan, which is more qualitative, and then the more quantitative piece, which has to do with the evaluation impact of the evaluation. Well, I think I've gone beyond my my time. That's what I have to say. I can go on for hours telling stories about Maison Bleue and the richness, the wealth that we see in the in the cultural encounters. And I was just again talking to Juan that we want very much to probe into. Okay, so we're in global health, to probe into the incredible. It's like in Caverne d'Ali Baba, you know, that what we find from the women that come to us, and the stories that they tell us is like we could spend books and books writing about that. I guess I should go on look at the chat, right, Marion? Do you have her in conference?
So Vanya, you can wrap up now, and I think we'll go to the next speaker, and then after we can address the questions in the chat.
Okay, perfect.
So Tim, do you want to pass it on to Kate Mulligan?
Yeah. So Kate, over to you. I introduced you earlier on, but welcome, and please correct me if I misidentified you in any way. But we're looking forward to your talk.
No, you got it right, Tim. Thanks so much for the introduction, and thanks everybody for being here. I really love talking about social prescribing, and Dr. Jimenez, I learned so much from your presentations. I'm really, really thrilled to be here with all of you today. I'm going to talk about the work that we've done here in the province of Ontario about social prescribing as a way to connect care and a way to build self-determination, to move away from asking what's the matter with you to what matters to you. So just to begin with a land acknowledgement, I'm calling from Toronto today, which is the traditional territory of many nations, including the Mississaugas of the Credit under Treaty 13, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. And now it is, of course, home to many diverse First Nations, Inuit, and Métis people. And I'm very grateful to be able to speak from this place today. So social prescribing, it really is a tool for health promotion. Really simply, the process of empowering people and communities to take more control over the relationships and the conditions for their own health and well-being. And health is something that is relational. If we weren't in relation with other people and with our environments, we wouldn't be living. And so we've seen this through COVID, how important it is for us to be in relationship with other people. And so social prescribing is really just a tool that clinicians and team-based care and partners across organizations can use to leverage the capacity that clients and communities already have, that strength that Vanya mentioned earlier in her presentation that people have, and at the same time help address their social needs and connect and integrate healthcare with social care. So as I've mentioned, we're all at a distance right now, and we've been reminded over the past year plus about how important it is for us to be together. And so we're, Canadians are expressing that they feel lonelier, but that there's something we can do to help connect people to one another and meet some of their other social determinants of health at the same time. And that's social prescribing. But before I get into the details of what it is, I really want to point out that social inclusion and belonging are equity indicators and are determinants of our health. We know that large-scale research has shown that early mortality and other health impacts come from being isolated and or being excluded from social life. And we know that in Canada, people who are already facing health inequities are those who are most likely to be isolated. So it's a compounding of isolations and of oppressions that people are facing. And this is by now a very famous map of the city of Toronto, where I live, showing the COVID rates across the city. And unsurprisingly, this map lines up very clearly with maps of racialization, maps of poverty, maps of housing instability and inequity, and many other measures of the social determinants of health. And if you're interested in learning more about that, there's a body of research called syndemics that's about how epidemics interact with one another and compound existing health stresses. But one of the things that's critical about this is that for many very isolated people or very marginalized people, the health system might be their only point of contact with community. And so we need to take an every door is the right door approach to reconnecting people with health promoting services. And so we started with the door that we have, which is in primary care. Throughout COVID, we've seen other organizations take up social prescribing as well, bring music to isolated seniors, addressing food insecurity through mobile health clinics and drop-offs, creating community-led pop-up COVID testing with culturally appropriate music and cultural supports to encourage people to be there. These are all the ways that people have started to think about broadening what they might have normally considered to be part of their work in healthcare. So here's social prescribing. Here's what it looks like. For our work, we did this work in community health centers across Ontario, which are much like CLSCs in Quebec, interdisciplinary, team-based, focused on meeting the needs of the most marginalized communities, but also community governed. And so their priorities are led by and for the communities that these organizations serve. So under social prescribing, I'll go through the different components of the model in more detail, but the core elements are that it's a structured pathway, a clinical pathway for referral. So in the past, we might have been offering social services and support like community kitchens, yoga classes, and so on, under the same roof as clinical services, but maybe not in a directly tracked way and through a direct referral. And so that's one of the innovations of social prescribing. The client sees a prescriber who identifies that there are some non-medical needs. Maybe those are the main reasons people are coming in. Maybe a person is coming in repeatedly because they're lonely, or they're recently widowed, or they need supports that go beyond what their clinical needs are. And so this wouldn't be a replacement for meeting their clinical needs, but a supplement to that work. The prescriber doesn't need to know the details of how to address that challenge, just needs to connect this person to what we call sometimes a social prescribing navigator or a link worker whose job it is to really listen, to take the time to listen and focus in a strengths-based way on what the needs of this client might be. And then to know the assets available within the health center and within the broader community, and to support that person to follow through. And then there are those social prescriptions, which are those, for the most part, pre-existing evidence-based programs that that we're well aware of that are health promoting. It might be spending time in nature with a group. It might be arts and culture. It might be those more material needs like food and so on. And then importantly, we have the data tracking component where we track the client's journey, we follow up, and we try to continue improvement through a learning health system. And that feedback, particularly back to prescribers, is really important to get a sense of whether this is working, whether this is something that should be part of their scope of practice and so on. So I've already mentioned some of these, but I'm going to go through a little bit of our findings and some of the comments that people made throughout our research about this work. The identification and referral through primary care is really important. Now, this could happen through many other avenues as well. And ideally, at maturity, social prescribing could go in many directions. But the way that we did it and the work that we did was through primary care and that long-term relationship that a primary care provider has with their client. So we know that a person will be presenting to primary care with some needs, but also with some gifts and some interests and some capacities, and that's a really important starting point. And that trusted health provider can help make the referral in a way that also carries a little bit of that weight of having been suggested by someone who knows something about health. And so the act of prescribing can be important for some clients to take this seriously and follow through. Then we have that navigator and link worker, as I've mentioned, who really asks, what matters to you? And we found this meeting with the navigator or link worker, oftentimes the very first meeting is just filled with tears. It might be the first time a person's been asked deeply what matters, with the potential of getting support for that. So there's a relationship that's built here, and then a plan is co-created to meet the needs of this person and to help the person follow through, maybe even going with them to the first few sessions, or using community development principles to create new programs and services where they don't exist. If a bereavement group is required, or you want to connect multiple people who have acquired brain injury or some sort of new thing, that you can build something new as well. And so that relationship building starts here. And then there are, as I mentioned, the social prescriptions themselves, getting people involved in many different kinds of activities across many kinds of organizations, and inviting people in to volunteer. And as you'll see with our findings, people want to help. And so if you are able to transform your sense of self from being a client with deficits or challenges or problems to being a community member with something to offer, that is tremendously health promoting. Here are some of the things that we tracked throughout the research. We tracked socio-demographic and race-based data, why people were being referred, whether they followed through, their self-reported health outcomes, and the experiences that they and their providers had. And I really want to stress those self-reported health outcomes because we only had a year to do this pilot research project. And so it's not really enough time to see longer term clinical outcomes, but also because we want to elevate self-reported health as legitimate and important indicators of our well-being. And so what we found was that the data part was challenging for people at first, particularly the non-clinicians who, like health promoters, for example, who had to learn how to use electronic medical records. But what we found was that people did learn. They might have thought that they did a lot of this prescribing already, and that this was nothing new. But then they saw through the data that actually, maybe they only did it once a month, but it was very memorable. And so we were able to get lots more feedback about what the practice really looked like and how we could shift into this more strengths-based approach. So here's what the research looked like. Our project was called Prescription Community, and we had about a year to do this with funding from the Ontario Ministry of Health. We worked with 2 groups of mentors from the United Kingdom, and I'll come back to this because the global movement around social prescribing might be of interest to you in your work on global health. We had 1,100 clients participating from 11 community health centers all across the province of Ontario, and 71 people went on to become leaders and champions in their own centers. So the map here is just by way of illustrating the diversity of the different community health center settings. So we had some in urban areas, some in rural, some in the north, some in remote communities, some English speaking, some French speaking, some serving new immigrants, some serving LGBTQ populations in particular, and so on. And so a lot of diversity and a lot of opportunity for each center to adapt and use social prescribing in a way that made sense for them. Here's what we found. First of all, there was a positive impact on the well-being of clients. And we had an amazing 49% decrease in self-reported loneliness over the course of this study, a 12% improvement in mental health, and a 19% increase in participation in social activities. And we have people saying things like, before I wasn't very good at accepting myself and looking after myself. And what I was taught here helped me realize that I could do something to look after myself, to improve myself, that there was something I could do. The next key finding was that it was a positive experience for healthcare providers, that by 9 months, 84% reported that this social prescribing had improved their clients' health and well-being. And 42% reporting that it had actually decreased their number of visits for clinical care. Now, this indicator is a little bit complex because we might see some people increasing the number of repeat visits as they start to take better care of their own health and well-being. But for many, and for decision makers and funders, this is an important finding that we can shift people, at least one step upstream for many of their needs and go to less expensive social care and reserve the clinical time of clinicians for that more clinical service. And so this is something that was very welcomed by providers. And finally, we did see that there was that deeper integration and co-creation across clinical care, interprofessional teams, social support provision, and community members. And this is just a small number of the community partners who joined in our work over time as they heard more about what we were doing and wanted to participate. And of course, it's going to look really different in different communities. Not all of those small communities across the province are going to have access to the Royal Ontario Museum, for example, although we've seen quite a shift during COVID toward creating more accessible opportunities for people. And even within our own centers, as I mentioned, the work theoretically was interdisciplinary, but in practice was kind of siloed between the health promotion and community development side of the house and the clinical primary care side of the house. And this work was really important as a way to break down barriers even within organizations to get these teams working together. So one of the key findings, something that I really want to stress if you're interested in taking up social prescribing in your own settings, and I hope you are, that people want to help more than they want to be helped. And that we need to help find opportunities to support people in ways that they feel that they are supported to give back. With one participant saying, this program said, you identify the different needs in your community and then create the solutions you need. It was a philosophy that we are creating the solution for each other that really spoke to me, and it's given back to me so much. And on the photos here are just a couple of pandemic adaptations that people have made to social prescribing, getting kids and families physically active online, dropping off care packages alongside healthcare information and support. And so what we found actually is that we're reaching more people than ever during COVID-19 after a period of being really uncertain about how we were going to get people together, doing all kinds of online, snail mail, supporting older adults to figure out how to get online, making sure people have access to devices and so on. And so we're reaching new people in new ways. And so going forward, this will continue to be part of the practice. I'm going to leave it there, just with 3 things that I hope you'll remember, as well as some information that I can also add the links into the chat box later if you're interested, about what we've done, how you can take it up. There's a guidebook for primary care providers. There's all kinds of resources. We have a new publication out about self-determination theory and social prescribing. And of course, we have those connections to the International Social Prescribing Network and Global Social Prescribing Alliance, to which we are members and active participants. So just to remember that social prescribing works best when everyone involved is empowered, that we want to take that strengths-based approach, and that we really do improve and learn best using learning health systems. That's all for me for now. Thanks so much.
Tim, are you going to moderate? That was what I understood, but I'm also happy to moderate if you prefer.
I'm equally happy to share the burden. I had a sense that we were going to defer to expertise in moderation, and therefore you were going to lead. But I'm happy to jump in if you like.
Good one, Tim. Good one. For those of you who don't know, Tim and I went to the same high school. And so we have this kind of little rivalry going on. Yes, well, for the expertise in moderation then, we'll have to get someone entirely different who's neither of us. So there are many very interesting questions in the chat, and I'm really not entirely sure where to start. So maybe we'll start going back to the very beginning. Professor Budgell, who is our Inuit health professor in the Department of Family Medicine, has a question that I think is specific to you, Vanya, for the Maison Bleue. If you ever encounter conflicts on reporting relationships and hierarchy among employees and professionals in a hybrid structure.
Ah, great question. I have to say that Kate's presentation made me sort of think of one of the outcomes, the most significant outcomes of Maison Bleue is the empowerment of the healthcare providers. In fact, if it's how I mean, we've been hit by maternity, I would say, and the reason why healthcare providers leave and come back to Maison Bleue is usually because they become pregnant. Otherwise, they they stay there. It's because there is a lot of competition, I would say, speaking about competition between you and Tim, Marianne, when a position opens, there's really a lot of people applying to come there. So when you talk about the hierarchy, the thing we learned as physicians, we have, if there is one group of of professionals that has the hardest the hardest life in interdisciplinary world, it's family, it's physicians, right? So it's us who have to learn most in general. For some reason, it's not in our DNA to the interdisciplinary work. And what happens is, it's very interesting when early on, I used to say, when residents come and listen to the interdisciplinary discussions that we have, they used to be sort of a little, how do I say, a little jarred by how robust some of the arguments that the social workers served to the family doctors were. And I used to one of them, I said, you're staying here and you're learning now. You just look at how it happens. The classic thing was the treatment of depression, for instance. So and I'm sure Marion remembers some of the cases where I would have loved to be able to start some of the antidepressants, and the social worker at the time was fiercely against that, and we had these very interesting conversations back and forth about what was the best approach. And so it's like Simone de Beauvoir or somebody someday said, "Il n'y eut jamais lieu que le lieu," which means that the thing that drives everything is the place. So the place being what it is, and Maison Bleue is an extremely humble place. It's a house, literally, that tiny. We kind of step on each other's feet. It's so small. But because it wants to resemble, it wants the population to s'approprier the place, feel at home there. So there's no other way than to work together. So the question you're asking about hierarchy gets sort of worked out around the cases. I would say that the physicians who come to Maison Bleue, usually they want to be there. They're seeking for that kind of thing. So I think if that's what you were aiming at about the hierarchy question. And the physicians are tourists in some way. They're the carrot that attracts the people, because none of us does more than, some of us do 2 half days there, but most of the physicians go 1 half day. The social worker is there all the time. The nurse is there all the time. The educator is there all the time. So it kind of, I would say, dilutes the extreme power, that the excessive power sometimes that is perceived on the part of the physicians.
Thank you, Vanya. So there are many interesting questions, but I'm sort of to ensure that we have input from everyone. I have a question here from Anish Arora that I think is directed to Kate, and I think I don't know how much it was already responded to in the latter part of your presentation, because it came early in the presentation, but what are some strategies that can be taken to effectively and efficiently adopt social prescribing navigators into care systems? So maybe you want to tackle that, because if you could answer that, then that would sort of solve all my problems.
Great question. So we did not receive funding for new care navigators or social prescribing link workers for this study. So we relied on existing resources within community health centers, social workers, health coaches, health promoters, nurses, and so on, to fill that role. And very quickly, what we found was it would be really nice to have a full-time role. That, it is okay, it is doable because of the resources within many team-based practices that are equity focused to make that happen, that it was really important. And in fact, one thing I didn't talk too much about was that we worked with 2 different groups of UK mentors. One that very much focused on changing the culture of the practice and using volunteers from within the client community to do a lot of the work. And one that was very focused on the link worker and that deeply clinical pathway. And very quickly, what we found was that all the participating centers, no matter who they started with, ended up with a hybrid of those 2. That they found that it was really important to take that self-determination and community determination approach, that otherwise it is just care coordination. And we know from the research that alone is not sufficient to really move the needle on health outcomes and build equity. So we needed that, but that given the particularly significant needs of many of the marginalized people in the population, that a link worker role was really important and needed, that we couldn't just signpost people and write something down on a prescription pad and send them on their way, that people need support. And many people need support for many different kinds of social and medical reasons. So, the best way to do this, from my perspective, is to start with the resources that you have. Maybe it's in a partner organization. The link worker role is not a registered health profession. If you can, if you have the skills to listen to people and to collaborate and to understand the assets available in your community, then you can be a link worker. And so that, I think that's the most important thing, is that we can work with partner organizations and others to leverage existing capacity and build sustainability. And that's what we did, because we didn't want to offer a link worker and then take it away after a year. And so I'm on a mission to see that Canadian health systems install link workers as they have in the United Kingdom, where this went from idea to full-scale implementation in less than 3 years. So that, so that's the longer term goal, that this should become a role that's supported by government. But in the interim, we can use community development principles ourselves to meet a lot of the gap, to demonstrate proof of concept and those kind of made in Canada approaches and locally appropriate approaches. So I wish I had better news about the funding, but I'm quite confident that it will come in the next decade, and hopefully a lot sooner.
Great, thanks, Kate. I think just following up on that, there might be a role for the dismal scientists in terms of looking at cost benefit of some of these newer types of workers, because it seems like there would be a good return on investment. So there may be an opportunity for economists to get involved at some point. I'm gonna, there are a couple of questions in the chat directed to Vanya about resiliency, and one from Juan Carlos Chirguin, another from Gina Kemp. But I think it was really to look at what is the directive or the fast track to resiliency when patients graduate from sheltered models of care, and how do families come together for long-term and sustainable resiliency. So I think it'd be interesting to hear that sort of that longer-term perspective, Vanya, from you. And Kate, you may have some thoughts on that as well.
I don't think I have an easy answer to what happens in the long term. Resiliency is sort of built. It comes by the breaking of the isolation. It comes by the and it's partly nature. It's partly nurture. So we know that some of the women and the families that we see are incredibly strong, unexplainably strong, in spite of horrible life trajectories. And I mean, I can tell you stories of a woman, in fact, who went through her whole pregnancy, came here as an asylum seeker from South Africa, because the father of the baby she was carrying was not from the same ethnic origin as her, which it's hard to believe, but she was rejected by her family because of that. So he fled to some other country, and she fled to Canada alone. She went, in fact, she crossed the border she came to the US, crossed the border walking. We took on the pregnancy, and she was found to be at risk for delivering early because of a very thin cervix. So the visits were done at home so that she would stay in bed, and she managed to have the baby at 9 months, and everything went well. Completely alone in her apartment with somebody living on top, and she's there's somebody that is renting her a room in the basement, and now she has moved to that first floor, and the people on top of that complain because she says the baby sings at night. The baby is now, I saw the baby a couple of weeks ago, adorable baby, and she's an amazing mother, all alone with this baby. And I said, he sings? She said, yes, well, because I sing to him and he sings with me. And so she sang, and I heard the baby vocalize with her. And and she is a extraordinarily competent woman and mother, perfect child. So had we maybe, okay, I'm not sure I'm exemplifying the resiliency piece, but had this mother not been seen at Maison Bleue, had she not had her visits at home by the midwife and the team, I'm not sure she would have had the baby on time. He would have maybe ended up in an ICU, premature something. So it's a resiliency that we built, but we built it on her resiliency. We and then there are other, I mean, we don't do miracles. There are other cases which are extraordinarily fragile, whatever you do, and it's never suffices, it's never enough. But we remember that the aim is the baby. Okay, so we are trying to give those babies the best trajectory possible. There isn't much we're going to change in the past or in the history of in what this family has gone through and what tools they have. We are giving them the best tools, but the aim of La Maison Bleue is ultimately the baby, the child, and the future of the child. So I don't think I can really answer more about resiliency than that. That just saying that it kind of it's trying to bring the best out of the people, and I have to say it brings the best out of us as well as healthcare providers. So I don't know if I've answered the question. It's a tough question about how to measure resiliency. I mean, we know it. We hope to. We have some little. There's a little boy that was a terrible two. When he used to come to my office, he used to destroy the place, and he's now a musician. He's so somehow now, is it Maison Bleue? Maybe not. Maybe he would have done it on his own. But you know, we have no choice but to do the best we think we are doing for the future of this little boy. Long answer for a difficult question.
No, great, no, and very helpful. Thank you. Kate, some reflections?
Yes, so you know, resilience is something I'm thinking a lot about in terms of this work I'm doing now with Dr. Tam's office. But my experience working in community is that many people really resist this term. They don't want to be called resilient. They don't want to be asked to be superhuman in the face of great injustice. And so we do have to be a little bit thoughtful about what we're really talking about when we talk about resilience, that we're talking about supporting people's ability to weather storms, but also collectively changing the circumstances under which our health is collectively created. And so by building the capacity of people, not just as individuals, but as communities, we're building something that's more sustainable, and that we're not just resilient within a closed system, and that could be at the expense of someone else's resilience, but that we're thinking about that collective capacity to sustain psychologically, physically, and ecologically, and so on, in a collective way. So I think that's really important. That we're still casting around for the right term to use or the right way to think about that, but that communities themselves really do bristle at the term, and that's something we're continuing to explore and work on.
Thank you, Kate. So both those answers were very, very helpful. And I think we do need to strike the right balance between sort of calling people resilient in the face of systemic injustice, and yet working with them on their own tremendous strengths. So maybe, because we have just a few minutes left, I'll wrap up with one of the questions from the chat that maybe both of you can also address. And maybe we'll go with, it seems to be addressed to Vanya, so we'll go with Vanya first. The question is from Jeannie Haggerty about what do you mean by the culture of portage?
The term portage is coined from in African. It's porter le bébé. It's the fact that women carry their babies skin to skin on the front. The Inuit moms carry them in their hoods for at least a year or two. It's portage. It's carrying. Okay, so what Maison Bleue? Well, my initial proposal was cultural portage in the sense of when you leave your country and you're from a different culture, the smells were different, the sounds are different, everything is different, and you arrive in it's like being porté par la mer, being carried by the sea, and you arrive in a place where it's not the sea, it's not salt water. You'll kind of sink like a stone, because nothing is carrying you. You don't have the music, the sounds, the words, the smells, the rituals, that's what carries you, the village that carries you as well. So that's what I was hoping to reinstate, that kind of portage, culturally adapted. I have to say, and again, I was talking to Juan Pimentel, and he was very sensitive to that. And I think we spoke about it, Jeannie, as well. It's that we have been so busy at the Maison Bleue in multiplying the model and finding the funds to open more, and that I have kind of neglected that piece myself. Which is really my passion, about really to reinstate that the taking into account the culture of origin of the family that arrives, which is a wealth for them and for us, and the moment you reinstate that connection, everybody is gagnant. It's great. It's a tool. It becomes a tool rather than a problem.
Kate, do you want to comment on anything related to that?
No, that was beautiful. I want to take that term forward in my own work. It was just beautiful, and certainly building culturally appropriate and safe health and well-being is such a critical part of all our work. So I just love that. Thank you so much.
So I see that we are at 1 p.m. on the nose. So with that, I think we will wrap up. There are many other interesting questions in the chat. So maybe one of our wonderful support people can take them and download them, and we can have further discussions on this. I want to remind people that there are also global health discussion groups and workshops. I guess they're actually called workshops, not discussion groups, that are also a joint initiative of the Department of Family Medicine and the School of Population and Global Health. And the next one, I'm going to look to Elaine, but I believe it's in 2 weeks from today. Is that right? The 26th of May. And so I would encourage you all to sign up. Please follow the Department of Family Medicine in social media or on our website, and you will find details of the next workshop. But for today, I want to thank both our speakers tremendously. I think this was an extremely rich hour of presentation and discussion. I think we all learned a tremendous amount. Kate, certainly I will feel a lot more valorized as a family physician because of the social prescribing that I do. I think there's a kind of hierarchy where we somehow think that pharmaco-prescribing is somehow better than social prescribing. And actually, I'm not sure that it is after listening to all the data you presented. And so that will be very valorizing for me. And Vanya, well, you know, I still have many Maison Bleue patients. I think I have about 25 Maison Bleue patients in my practice, including some of the most heavy cases, and they remain the most heavy cases in my practice. So when I'm tearing my hair out, I go to say to Vanya, that was a Maison Bleue patient that I lost an hour of my afternoon trying to figure out, because of course, when they come to follow me to the CLSC, I don't have the whole multidisciplinary team right there sur place. I can find them, but it's a lot more work for me. So yes, so the fascinating discussion today. Thank you everyone for your attendance, and thank you very much again to our two speakers. Thank you, Kate, for joining us all the way from Toronto, and Vanya from all the way from upstairs. And à la prochaine, everybody. Have a wonderful rest of the week.
Thank you. It was wonderful.
Thanks.